Thank you so much for joining us this morning. And we are going to be discussing prone breast radiotherapy, specifically giving an overview, discussing some setup considerations, as well as utilization within MRI.
We're not able to advance the slide. Here we go.
Okay, so we can start off with just giving an overview of breast radiotherapy positioning, as well as some immobilization considerations. So the most common treatment setup for breast RT is the supine treatment with arms up. And this provides quite a bit of flexibility when it comes to treating the whole breast, as well as any involved nodes. Even a two-field treatment is sometimes used to treat level 1 and 2 nodes. Additional fields can be added to treat the clavicular nodes as well as the IMNs. But this treatment has been very successful and has again provided quite a bit of flexibility when it comes to treating additional target sites. Breast conservation surgery plus radiotherapy has been shown to achieve the same outcome as mastectomy for both local control and survival. However, patients with large breast sizes who are treated supine have been known to experience increased rates of both acute toxicities, and some examples of those are breast pain, erythema, and moist desquamation, as well as chronic toxicities like fibrosis, retraction, and breast distortion that lead to poor cosmesis. Attempts to address these limitations have come in the form of the introduction of mixed energies to the treatment fields, mobilization devices that displays the breast from the chest wall, as well as modifying the patient treatment position. And we're going to be focusing on the latter of these two a little bit further. So just looking at a couple of immobilization devices, two common ones are the Chabner bra and the breast cup. The Chabner bra, shown on the left here, significantly reduces inframammary folds, which is an area of skin toxicity, common area of skin toxicity. It increases comfort and modesty, increases setup reproducibility with minimal skin toxicity. And a single institution study also showed that there were lower lung and heart doses as well when the Chabner bra is used for treatment. The breast cup, similar to the Chabner bra, reduces the inframammary folds. It could increase setup reproducibility and also increases the distance between the irradiated breast tissue and the heart. So as shown in the image, this is the breast cup here, and how it looks during the treatment plan is that it brings the breast tissue further away from organs at risk, such as the lung and heart. So this is the treated breast compared to the contralateral breast that does not have the breast cup. Are we having audio issues, or are we okay to proceed? We'll continue on that. So an example of a different treatment position is lateral decubitus. So this is shown in the top right image. And this treatment position can significantly decrease the breast separation. It reduces skin overlap in the inframammary fold as well. It introduces challenges, though, with day-to-day reproducibility and can result in increased skin dose to patient due to treating through the table. prone position is another option when it comes to modifying the patient's treatment position. And there are many options for prone breast boards. The fundamental concept is generally the same across all the available options. The differences between the different options will come in the form of patient comfort and treatment clearance. But the idea is that the patient lays prone with the treated breast uh, uh, laying in an opening that makes it accessible for treatment. So an example of the impact that prone has on the breast anatomy is shown on the bottom right images. So the left is a supine treatment, and we can see that the breast tissue lays laterally on the patient. This increases separation, and if the whole breast tissue is to be irradiated, part of that beam is going to go through the heart. That same patient is simulated in the prone position. The breast anatomy drops further away from organs at risk, which could increase or reduce the likelihood of that treatment field going through organs at risk, again, like the lung and the heart.
It's also a good example of how the separation significantly decreases when you put a patient in prone as opposed to the supine position.
And another benefit of prone is that it also eliminates skin overlap in the inframammary clone. However, if the breast is pendulous or significantly pendulous, it may puddle or pull on the table, increasing the challenges with reproducibility. So we're going to be transitioning over to some setup and imaging considerations for prone breast radiotherapy. And going forward, the rest of the discussion will be focused solely on prone. So some questions that often come up either at simulation or during treatment planning are some of the following. So can the patient tolerate or be comfortable enough to tolerate the setup for the duration of the treatment? When it comes to the treatment setup, is the patient leveled? Is there belly tissue that can impact how the patient lays and therefore impact the daily setup? Does the contralateral breast and how the contralateral breast lays on the board impact how the patient is laying on the prone board and therefore also impact daily setup? Are we able to treat the whole breast without treating through the treatment table? Is daily imaging necessary to assist with setup reproducibility? Are there options, technological options like surface monitoring that is needed for setup and intrafraction monitoring? Or finally, is there puddling or pooling on the treated breast that needs to be addressed? We're going to be looking at, we can spend a long time discussing each of these points, but today we're going to be focusing on the latter three and looking at each of these individually a little bit more. So is daily imaging necessary to assist with setup reproducibility? Depending on the patient population or the experience of the treatment team, unique imaging protocols may be required to verify patient setup reproducibility. Again, this can vary from imaging weekly or imaging every day. An example of a daily imaging protocol is shown below. So on day one, KV-APPA images are acquired to verify the lateral offset of the patient. And the patient is repositioned if they are offset by more than 2 centimeters. Also on day one, 2 lateral KV images are acquired. The first uses an imaging technique to visualize the chest wall in order to verify the patient's depth or vertical positioning. The second image is used to visualize soft tissue in relationship to the body contour. And when necessary, the soft tissue is manipulated and the couch is not shifted greater than 5 millimeters. On day 2 through end of treatment, only tangent images are required to ensure that the soft tissue is aligned within the body contour. And the breast anatomy may be manipulated and placed in the appropriate position as long as it does not exceed the 0.5 centimeter tolerance. If that exceeds 0.5 centimeter, then we can revert to day 1 to verify that the patient's depth and laterality is appropriate, or lateral positioning. If the couch position is flagged by the software, acquire another KVA PPA image to verify the patient's lateral offset on the prone insert. And the patient is repositioned if the shift is greater than 2 centimeters. So again, this is an example of a daily imaging protocol, but something like this with modified tolerances can be used for patient setup reproducibility, as well as aligning the patient daily. The next question that often comes up, is there surface monitoring needed for setup and intraflexion monitoring? So there are technologies like Align RT that may be used to assist with patient setup and motion monitoring during treatment. What you see on the right is an example of guidelines provided by Vision RT, which is the vendor for Align RT, on how to contour the surface of prone patients. So they suggest to include the breast tissue and ipsilateral and contralateral shoulder, including the scapula, and do not include the arms or upper shoulder because of day-to-day variability in these anatomical regions that can increase the uncertainty of the Align RT setup. So this is another example of technologies that can be used to increase the setup reproducibility of prone treatments. This is not a common use of additional technology, however. And the final question here, is there puddling or pooling of the treated breast? So all patients are simulated on the prone breast port, which can either come in this form, which has risers that support the patient, or as a table insert shown here. The table insert is dedicated for treatment only, not for simulation. However, at treatment, the breast could just be suspended, or it could puddle on the table. If it does not puddle on the table, this is great. The patient can be treated on the floating prone insert, and that means that for treatment, you have a little bit more clearance and beam angle options. If the patient puddles on the table, then they will have to be treated exactly the same, using the same setup that was done at the sim with the risers. They can no longer be suspended on the prone breast insert. And this image on the right shows how a breast that puddles look during treatment planning. So how do certain clinics handle this? So this is an example of the additional steps that are taken during a prone simulation when the breast puddles. So there is the skin marks that are standard for all prone, but then the breast is outlined on a template or a sheet of paper. And this image on the right shows a closer look at the how that the breast is outlined on the sheet of paper. And then there are additional marks drawn that indexes that paper or template to the table itself. And then that template is further abutting the upper risers of the prone setup. And again, this is all in place to increase reproducibility at the day of treatment and every fraction thereafter. So it's additional work, additional steps, additional indexing parameters that need to be properly documented if accurate treatment positioning is to be achieved every single day. So now we're going to transition to the impact of prone utilization on cardiac sparing within MROC. So we discussed that patients with large breast sizes were known to experience increased rates of both acute toxicities and chronic toxicities that resulted in poor cosmesis. Prone setup was used to address those issues and limitations with the supine treatment. But prone setups were also quickly found to reduce those cardiac structures and lung in most patients. So a retrospective investigation was initiated within MROC with the goal of investigating the impact of patient and treatment characteristics on achieving a retrospectively applied conservative mean heart dose and lumpectomy planning target volume coverage metric. So this is again achieved through retrospectively applying these mean heart dose and PTV coverage metric to patients treated within the consortium and assessing what percentage of patients would have been compliant with those metrics. The covariates of interest for this retrospective analysis were breast size, heart size, breast separation, age, body mass index, and treatment position. And for treatment position, we're focusing on supine, supine with motion management, and prone. Motion management was defined as patients treated with a breath hold device, such as ABC, SDX, or a gating device such as RPM or Align RT. The patient split for motion management were about half and half. So 47% had motion management and about 53% had no motion management. And then for treatment positions, 76% were treated supine and 24% were treated prone. Again, the performance metrics that we are looking at are a PTV coverage metric, defined as at least 95% of the lumpectomy PTV receiving at least 95% of the prescription dose from the whole breast plan. The mean heart dose is defined as the heart receiving a mean dose of 1 gray or less from the whole breast plan. And the composite metric is meeting both the lumpectomy PTV coverage and the mean heart dose metric. There were 2,492 patients in this retrospective analysis. All of those patients were treated between 2018 and 2022. All had moderate hypofrac with daily fractionations ranging from 2.5 to 2.8 gray per fraction. All patients were left sided cases, and they were all node negative. If there was a boost plan present in the patient's treatment course, the boost plan was excluded from the analysis. And the final criteria is that all planning structures needed to be TG263 compliant. So this is the breakdown of the breast volume. So there were 4 quartiles that were introduced. Quartile 1 were patients with breast sizes less than 720 cc's. Quartile 2 was 720 to about 1065 cc's. Quartile 3 was 1065 to about 1500, and quartile 4 was about 1500 cc's. All quartiles had roughly the same number of patients. So we're going to be looking at 2 figures here. Initially, we're going to be focusing on figure A on the left. The x-axis has the different breast size quartiles, which are shown here again for reference. But quartile 1 consists of patients with the smallest breast sizes, and quartile 4 consists of patients with the largest breast sizes. The y-axis is the percent compliance, so the number or the number of patients, percent number of patients that meet the different metrics of interest. The black bars show the composite metric, meaning these are the number of patients or the rate of number of patients that met both the mean heart dose and the PTV coverage metric. The hashed bar is just for the mean heart dose, and the white bar is for the PTV coverage metric. What we're seeing here is that patients with smaller breast volumes tend to have a higher likelihood to be able to meet the mean heart dose metric, as well as the PTV coverage metric, and the composite metric as well. And these values tend to decrease as you increase breast sizes, except for the PTV coverage metric. That remains relatively unchanged regardless of breast size. If we focus solely on the mean heart dose metric, since that is what is driving the decrease in compliance rates, again, the y-axis is percent compliance, x-axis is the breast size quartiles, with Q1 having the smallest breast sizes, and it increases towards Q4, which has the largest breast sizes. Here we are looking at treatment position combined with motion monitoring. So the black bars are supine treatments without motion management. The hashed bars are supine treatments with motion management, and the white bars are prone treatments. And we see that a couple things to take away. As you increase breast sizes, the compliance with the mean heart dose does decrease. However, prone outperforms supine with or without motion management quite significantly, and it is more drastic in patients with larger breast sizes. Supine with motion management is a good technique that does outperform supine without motion management, but it is not as good as prone when it comes to meeting the mean heart dose metric within this patient population. We are honing in even further into the data set here. So we're looking at both the mean heart dose metric only, and now we're focusing on patients with very large breast sizes, defined as those having breast sizes of 2,000 cc or more. And we see the same trend where prone positioning significantly increases the likelihood of being compliant with a conservative mean heart dose metric of 1 greater or less, followed by supine with motion management, and then finally supine without motion management having the lowest compliance rates. This figure here shows the different covariates and the odds ratio, or the likelihood of being compliant or non-compliant with the mean heart dose metric. Compliance is indicated by a point further to the right, and non-compliance is indicated by a point further to the left. At a glance, we can see that age group does not significantly impact compliance, neither does BMI. Breast size does not impact compliance up until you get to very large heart sizes. So 690.1 cc or greater heart was trending towards increasing compliance with the mean heart dose. And then breast size decreased, or rather trended towards non-compliance. And as the breast size increased from 720 cc in the second quartile to over 1,500 cc in the fourth quartile, non-compliance increased as well. Breast separation did not impact compliance significantly. And finally, treatment position, as indicated within the prior slides, supine with motion management increased compliance, and prone increased compliance even to a greater degree. And these are the reference that were cited in the slides as well. And we can transition into our Q&A.
Great job. All right, well, I guess there were some questions that have already been submitted. And I'll just say that one of the main reasons that Alex gave this presentation was that we know that many of you who are not part of the breast working group were asking questions about prone positioning. Because this is a metric that is consortium wide. So we thought to talk about it now and to have interactive discussion with members of the consortium would be very helpful. Actually, I don't know if we want to start with our questions. I see we have why don't we start with the questions and then we'll get to, these were already submitted. Our facility only treats patients with SBRT supine. Can this be added to the listed exclusions?
It's a little tough because
SBRT.
right, and it's a facility specific limitation. We don't have any data that kind of shows how SBRT performs with respect to cardiac toxicity. But we do know that prone is really good.
And also SBRT is only going to apply to a really, really small percent for breast patients. We're talking about whole breast or partial breast. And I would assume this would only be relevant in the partial breast. So in addition to your thoughts, I mean, I think the absolute magnitude of this wouldn't be a problem. And we have to remember that the highest level is 30% in terms of our points. So there's a lot of latitude.
But, and then this is, so all breast patients that come through this facility, they're only treated with SBRT.
I think they were saying our facility only treats patients with SBRT supine. So for those who get SBRT, it's only done supine. I think that's what they meant.
Okay.
Right, which is, it's a really small percent.
Right.
You're talking about breast cancer, definitive breast cancer following breast conserving surgery. So it's going to, I assume it only would apply to partial breast, if at all.
Right, which in that case, it should not be listed as an exclusion criteria.
Correct. Right. That's right. Really, really small. Good trick question.
It is.
Frank, do you want to take a second?
Yeah, sure. The question is, DIBH has also been shown to effectively reduce heart doses. So our physicians often use DIBH for left breast cancers. Could DIBH be added as an exclusion? You know, I've kind of come full circle on this. I mean, having been involved with the initial studies to use the active breathing control device to treat left-sided breast cancer, to spare the heart, you know, our clinic was geared towards doing DIBH. But now, having seen a little more practice with the prone positioning, I can tell you that based upon Alex's data showing that it's actually better in some cases than DIBH. And also DIBH takes longer to treat the patient. And that's kind of a difficult thing in our clinic. And it's more difficult on patients, I think, than the prone positioning. So even though you're taking into consideration cardiac sparing by using the DIBH, I don't think it should be used as an exclusion. I don't know what you think, Lori.
No, I agree. And again, when we talked about this as a working group, the breast working group, and we thought that having 30% gave a lot of latitude so that people wouldn't have to make dramatic changes. If you got very good heart sparing with deep inspiration breath hold, and if you want to do that, that was fine. You still could then use prone for other patients. But I think an important point with this is that obviously heart sparing must be first and foremost on your mind when you're planning these cases. And two, as a part of this metric, we're asking physicians to write down why they chose what they did. So that this was a great suggestion from one of our members at MROC. And I think that will give us some feedback for why people are doing what they're doing. But I would not put it as an exclusion. I think it is a tool that certainly can be used. But as Alex showed very nicely in the data, even when you look at patients who have some type of motion management, you get even better heart sparing for most patients with Crohn. So I think this is a learning, we will
Yeah.
learn a lot from people's experiences.
Absolutely.
Yeah, and there are some patients that may not be able to tolerate the IBH, for which
Yeah.
Crohn might be a good option.
I'm glad you brought that up. It's actually one of the questions that you listed that we didn't go back and talk about, or how do people tolerate Crohn? And I'll give you my experience. I'll be very interested, Frank, for yours, is that you have to get a person used to it at time of sim. But for the patients that I've done with maybe one exception, once they've gotten used to it, they've actually said, oh, this has actually been easy. So it's like anything else. Once they have done this, it has been easy for them to do, and if done correctly, as Alex said, it's been reproducible. Frank, what have you
The
found?
same experience.
Right.
As I mentioned, the IBH, I think it's harder with ABC device than it is Crohn. And so if the patient can tolerate Crohn, going towards that direction lately.
Yeah.
Yeah.
do that.
That one.
If the breast is not pendulous, our sim therapist and physician use their judgment to determine whether a patient is a good candidate for Crohn position. Could physician preferences be added as an exclusion? Our data shows a broad range of breast sizes. And one can deduce that the smaller quartile or smaller breast patients are not as pendulous as those in the higher breast sizes. But across the board, all breast sizes benefited from prone positioning over supine with motion management or supine without motion management. So I think it should not be included as an exclusion criteria. And so that's the first, I guess, justification. The second one is that we already have a cutoff for breast size included as an exclusion criteria.
Mhm.
uh, that already would account for patients with smaller breast sizes that would not be as pendulous as slightly larger breast sizes.
Right. You know, I add, physician preference, physician judgment should always be an important part of patient management. And if the physician or the team feels that that patient's not a good candidate for prone, you absolutely then should treat them supine with motion management. And so again, that flexibility is there, given the system that we've set up with the cutoff being 30%, and to reflect that it was the judgment of the team that the patient would be better served for whatever reason, X, Y, Z, should be listed on that form. Again, so we capture information and we can share it with the group after the first year of this metric. But I would always go with your gut. If you think that that patient is better served by a physician that's not prone, then absolutely don't do that. I don't know, Frank?
Yeah, I agree totally.
I'll take the next one. Can B cups be added to the definition of small breasts? So we had the working group, we had these discussions, and it's very hard when you're talking about A cup, B cup, C cup, for it to get objectivity with that. So we thought, looking at prior studies done elsewhere, that we should come up with an absolute size. And so we came up with 1,000 cc's. You know, it's a small breast, medium breast, large breast. And there's certainly a continuum along that. And we thought that very small breasts would not be good candidates, very large breasts would be, and it's that middle group, and that's what you're asking about here. And I think that's where it comes to the judgment of the physician or the team. And if you think that that size, the patient has a size breast that would be better served by a supine physician with motion management, do that and then list that on that form. Again, we are very much in a data capturing learning mode. Excellent suggestion from a member of the consortium, and I think we'll be able to discuss this going forward with data. I don't know, others, your thoughts?
Totally. It's a learning experience.
Yep. Yep.
I can take the next one. It says APBI is not eligible for prone, so can this be added as an exclusion? Well, APBI is eligible for prone, but there's actually large experiences published with. I think it's the question where the cavity is in relationship to the chest wall for PBI, whether or not prone is better or not. So I really don't think PBI should be used as an exclusion, Mallory.
Yeah, no, I agree. As we're all getting more experience, Dr. Vicini has a ton of experience. As we're all getting more experience with PBI, I think there's some patients who are treated very well with that prone.
Absolutely.
So it's a judgment thing.
The last question, right-sided breast patients, can these be added as exclusion? So for right-sided cases, the cardiac structures are not a concern, as big of a concern. But there's still,
Occasionally.
Yeah, like I said, not as much, but sometimes it's surprising. Yeah.
but there are other benefits to prone, such as decreasing breast separation and eliminating the inframammary folds that can result in greater toxicities. I'm honestly split about this one.
About whether she be excluded.
Right.
No, I think, as you said, that for a certain size breast, it's still the dose and homogeneity
Mm.
that you want to minimize so that you don't have toxicity, both acute and chronic. So right side breast can be as big as left side breast, obviously. And so while the cardiac concern is not generally a major concern for those who have right-sided lesions, the breast size and the issues associated with that, and then there may be some lung issues that, depending upon the contour of the chest wall and how the lung fits in, that perhaps that would be lessened by prone. But I think most likely it's the size of the breast and the dose of homogeneity that would guide you for right-sided. So again, plenty of room to make that decision and to decide whether to use prone or not. All right, great questions. I must say these questions really all focus almost all exclusions, and it's almost, I think part of this is we're all trying to learn how best to use prone, and there may be some resistance, but I hope as more institutions use it more, that you will see the positives of prone positioning, because from a patient perspective, it's generally very well tolerated. All right, I know we've got questions. So how
Yes.
do we bring up the questions?
So I am going to let Dr. Fetterman, who has been patiently waiting with his hand raised, I'm going to unmute him and then he can ask his.
Mark, are you there?
Is my speaker working? I had some
Yeah,
connection.
yeah, we got you now. Hey, Mark.
You're on.
All right, great. Yeah, I didn't interrupt earlier on a comment that I have some pretty strong feelings about. And the bigger point is the second one that's tied to it. I don't still understand what the issue is with being opposed to daily imaging on such a high-risk variable setup. We obsess with the precision on how we do breast treatment. We're obviously getting more relaxed now for protecting heart tissue compared to computing all breast tissue, but it's very easy, very quick, very low cost, relatively speaking, to the treatment to do the daily imaging. And if we don't do it right, and there's a lot of potential variability, a millimeter roll can cause a difference. The biggest issue not mentioned earlier is how do we compress these large breasted women's opposite breast? And if that's going to be pushed differently one day or another. So I think our techs are good and do a great job at doing it, but imaging gives them increased security. But the correlated that I didn't hear on your protocol is we're doing cone beam CT scan in all these patients, because we've had more than one patient actually show breast reaction earlier on a few years ago on the contralateral breast, and re-looked at it and realized that the most reliable way to do it was cone beam CT scan. And I had a patient just this past week that looked like a very good plan, but a newer dosimetrist. And when I very carefully looked at it, I realized there was a lot of possibility with a very small variation of that opposite large breast being compressed on the opposite side, rolling into the field, and had to change the plan for it. So our protocol is to use cone beam CT scan for all these patients. And I think even considering not doing daily imaging for this is problematic. They can't see what's going on with this breast very well. We can't see what's happening the other side. So thanks.
Yeah, that's a great comment, and that's been kind of my experience as well, working with our therapist and learning about what their concerns are. And yes, we also use daily imaging by default. We do also rely on our physicians to kind of guide us as to which patients that is just not appropriate for. But we completely agree that that gives our therapists a significant boost in confidence in knowing that the target is where it should be. And we're also experiencing tons of variability introduced by the contralateral breast for larger patients, excess tissue in the belly area, arm positioning that's not may not be reproducible, even with a wing bag on a daily basis. These are things that are mitigated by daily imaging, and again, give our therapists a significant boost.
So Mark, I'm gonna play devil's advocate here. What you said absolutely is right. For a large breasted patient who also has a large contralateral breast and there are setup concerns. Let's just say that as we've become more comfortable using prone, we continue to see, based on our data, that we're using it for smaller breasted patients. So let's say that moderate sized breasted patient, where the opposite breast is not an issue, setup is beautiful. Would you still mandate that person be imaged daily, given the dose of radiation going to other parts of the body that wouldn't necessarily have to be done if her setup has been shown to be reproducible?
Am I still muted or not?
No, you're there. We can hear you.
I see no sign on my screen where it is. I would still strongly favor it, because we all know from experience in our supine setups as well that very small position setups can lead to very large changes. Whether it be the arm that we're not imaging with a line RT, which we do use, by the way, for this also, it has been helpful. Just a very small arm change can cause a positional coverage. And obviously we're building in margin, and we have competent techs that are doing it and very skilled at what they do, but it's a very easy thing to check on it. The issue with the smaller breast women going prone, which is a smaller grouping, then the issue is not going to be so much the contralateral breast, which I'm really worried about each time getting radiation dose when we would want to give it there. Then I'm worried about the roll effect and or other position changes that we might have more tolerance on. But if the whole issue is to be protecting normal tissue, we might be moving it. So I've heard numerous presentations from NCCN and other academics on why we don't need to do daily imaging for breasts. And I'm not convinced of it. And I think that the arguments I made for the large breast is because of that particularly horrible situation I'm seeing or afraid of seeing. But you can make the same argument for each of the scenarios we're doing in the prone position. And for that,
Yeah.
line.
So on that, we will agree to disagree. Because I must say, for a smaller breasted patient, I'm talking about the middle-sized patient, middle-sized breast. If I have gotten to the point where I am confident that their setup is correct, I would not really want to expose them again we're giving mega doses of radiation to the treated breast, but it's other areas that I would worry about unnecessarily exposing them to low dose radiation. So I think it's a great question. And I think this back and forth shows a lot that what we need to learn about this. But the first and foremost, we got to make sure that what we're treating is being treated correct. And if you don't feel that's being done, then daily imaging absolutely is what is necessary. So I think it's only if you've been given that sense of security that it's going well, that perhaps you can reconsider that. But it's,
A corollary to that, by the way, which isn't imaging, but it ties into this topic of the setup, was referred to earlier, and that's the abdominal roll. And that's actually been a limiting factor for some of the patients for me using prone, has been if the woman has large body habitus on their belly, then it becomes a problem too. And also another area to look at. So just as additional factor on that.
I know we've got a lot of questions. We're running late, so we'll go on. Thanks, Mark.
Sure.
Mark.
All right, I'm going back up to the top. Sorry. Oops, slides are moving.
I know.
Okay.
We'll make it up later.
Okay, don't worry, we'll make it up. Yes, Larry's right. I was actually starting to worry that we were going to have a lot of time, so I'm glad people put questions in. So, first question after Dr. Fireman had raised his hand was, to those of you on the panel, can you give some advice on how to get the treatment team, especially the therapists, to embrace prone?
So I think, at least my opinion is that The therapy profession is very hands-on, and from what I've gauged with my interaction with them, they feel more confident and comfortable with treatment techniques that they've practiced quite a bit. You know, at some point there needs to be a starting point. But one cool thing about MROC is that we know which facilities are doing prone, and we can just do a knowledge transfer session. My clinic is more than happy to host individuals that are interested in seeing prone setup in action, both during sim and treatment, so that a group of therapists can at least perform a dry run. So that's another example or an example of how they can get more comfortable with that particular treatment. It is not a simple treatment. The benefits are significant, but the setup itself is not simple. Others may disagree, but I consider it a very, very difficult setup. I don't know if that answered the question.
You know, I will say, I think it's a great question. If the physicians want to use prone, and hopefully they kind of set the tone, I think MROC would be a wonderful way of being able to work with, as Alex said, to have people to come visit for institutions that do it, so they can see. And then maybe similar to the lung work group, at one point they did a roadshow for motion management, that we could then come to those institutions, so that there would be that transfer of knowledge. So I think MROC would be a great way of doing that, right?
Yeah.
So looking through a lot of the other ones, I feel like we have a lot of comments versus questions. Good comments though. And I think and you all correct me if I'm wrong. Some of it got brought up when Dr. Fireman was speaking and some stuff. And I can see Ian. You guys can't see Ian. I see you nodding his head. This is the power of being the host of the webinar. There is one question, and I'm actually happy to take this one. And so it comes from Dr. Hoffman up at McLaren Northern, and that's about you know, so their clinic is close to 100% compliance with heart dose using deep inhalation breath hold, and the patient population that they serve who would benefit for prone position would be small. And so he's asking, how do we justify to our hospital the capital investment to purchase a prone board? And so for those who aren't aware and not active on the working group, there are 5 facilities in MROC that are currently do not have prone capabilities because they do not have a prone board. I want to actually give a huge shout out to a member of our executive committee who is an administrator with the Henry Ford Providence, the east side Henry Fords, and that's Karen Roskowski. And Karen has been working with me to kind of help on a few things with getting some boards. And actually, Karen made my morning because she sent me an email this morning saying that 2 of the facilities that we were trying to help are going to be able to purchase boards. And we're working on helping the other facilities. So if you are a facility that does not have a board, we are happy to help you. I know that there's a couple in the McLaren system, and so I have been working with someone over there trying to help. But that, you know, totally understand that, but we definitely are here to help from the coordinating center standpoint as much as we can. We do have one question. Does anyone have data showing that prone treatments are faster than deep inhalation breath hold treatments on average?
There's data. I'm just going anecdotally on some patients with at least the ABC device for left sided. In many cases, I've seen in my own experience, prone is easier, quicker, But that's a generalization. I'm sure it can be just the same in some cases.
We also do, how many cases you've been prone? I mean, it's a learning curve.
Yeah,
And,
that's true, yeah.
when
Yeah.
you've done
And
quite a
10 to
few,
1 is
if
the
you
average
asked,
age. Yeah.
you asked Sylvia Fermente, who
Yeah.
was one of the queen of prones, she would say, just like
Right.
that, but then they do so many prones, so part of that has to do, I think, with your use, your frequent use of prone.
And then is that question also just the delivery time or setup plus delivery time?
I'm assuming it's the whole thing, so yes,
Yeah.
yes.
Yeah, treatment team experience, could impact that significantly. As well as the imaging protocol, if there's daily
Yeah.
imaging involved, that adds time. If they're treating, a prone patient a month, that also adds time because, there's a lot of time in between each of those treatments. Yeah, a lot of variables.
Yeah, again, they're generalizations. The physician can decide which technique is best for their patient. We're just trying to push the idea that many more patients are probably candidates for prone. I can tell you my experience, I've adjusted it through the years, more prone lately. And I'm glad that MROC is pushing it, to be honest with you.
Yeah. I will say the same thing. I did not utilize prone frequently at all, and I'm doing it more, and I'm not sure why it's taking me so long to do this. To come on board because I'm seeing more and more positives, but again, it's just my getting used to it
It's a question
and
of
our
use.
institution.
Yeah.
I mean, some of the therapists, I mean, it takes time to get used to it, but I'm already seeing that they're saying, oh, good, we have another prone patient, for some, oh, we're doing, so it's flipped now, in
As
the other
opposed to
direction.
why are you doing
Exactly.
that?
Are you sure, Dr. Pierce, you want to do this person prone? Right, actually, I know we're running out of time, we've run out of time, but there seems to be a lot of questions about partial breast IMRT. And I think we need to look at that because I'm seeing a lot on that. Alex, do you wanna?
And Dr. Bergsma had a good question, but it would require the coordinating center to run some data. So
Yeah.
it sounds like we know what we need to talk about at upcoming working group calls. We need
That's a good point.
Yeah.
Made.
Can we just can you just address the IMRT and whether you can do a prone patient using IMRT? Because there seems to be a feeling that doesn't work well.
Yes, you certainly can do, treat prone with IMRT. A common one, as we discussed earlier, is treating, prone APBI with IMRT. And that, an indication for that it would be if the breast is very pendulous, and has a large separation if treated supine. And having to treat that with APBI, would not generate a good-looking plan. It would be significantly better to treat a pendulous, pendulous breast patient prone, if PBI is the treatment intent.
Sounds like it'll be a discussion point in the working group. And then one last thing, I saw he had a note about medial lesions and prone. And it may be that the position of that lesion, especially if it's closer to the chest wall, that prone is not a good option. And so in that particular patient, you would note, I've treated this person supine with motion management because prone would not give a good, and so note that on that form. Because I agree with you. First and foremost, you got to make sure you got to treat the target, treat it correctly. And if you have a medial lesion that's close to a chest wall, prone is not the right choice for you. Right. So good point. Okay. These are we do have a lot to take back to. This is great discussion and thank you for comments. This is fabulous. Thank you,
All right.
everyone.
Thank you. So Frank and Alex, you can go relax.